I should say that what I'm going to present today, a lot of the data is going to be coming from an international survey that surveys what the Commonwealth countries. So it's about 11 countries, including Canada. And there are going to be results I'm going to show you from the 2019 survey of family doctors, primary care physicians, and as well as the 2020 survey of the general adult population. And I'm also going to share with you today some of our own findings from work we've done comparing Canada to other countries. So what can we learn from other countries that actually are doing better than we are when it comes to everyone having a family doctor or place of care or primary care home, as we often talk about? So this graph actually shows Canada in comparison to a number of other OECD countries that actually have higher rates of what I call primary care attachment. So that's people having a family doctor, a nurse practitioner, a physician assistant, some kind of regular primary care clinician or regular place of care. And so you can see Canada here on the left. And then on the right, you see these other countries like France, Germany, New Zealand, the UK, Denmark, Netherlands, Finland, Italy, and Norway. So all of these countries actually on the right have 95% or more of their population with access to primary care, which is really different from our own country. When we look at these other countries, we might want to understand what are they doing differently. And I think one big thing that we often jump to is it just that they have more family doctors or what they call general practitioners or GPs? And actually the truth is when we look across these countries, that's not true. So you can see Canada being on the graph there in that big red circle. And what we have on the x-axis is the number of general practitioners per capita. And on the y-axis here is the rate of attachment. And so the higher the attachment, the better. And you can see that some countries with really high attachment do have more general practitioners or family doctors than in Canada. But some countries actually have fewer per capita, or at least the way these are counted. But interestingly, that doesn't tell us the whole story, because actually when we look at all doctors in the population, one thing we do see is that compared to other countries, Canada actually does have fewer doctors overall than these other countries. And so that may be part of the story here. So we see the total number of physicians on the x-axis here, and we see Canada kind of being the lowest number. And then we see the percentage of people with a regular primary care provider or place. And you can see these countries all have higher doctors per capita than Canada, as well as higher attachment. So that seems to be part of the story. And actually, as many of you might know from the news and the reading, Canada actually made some very deliberate decisions back in the 1990s to reduce medical school enrollment and residency training. And there have been a number of news stories now that that's really costing us because there are fewer doctors as a result of some of those policy changes. But I will say, when we're looking at these numbers, we have to be really careful because the numbers of general practitioners or family doctors per capita can be really misleading, because not all family doctors are practicing what we think of as sort of regular family practice. So what we often refer to as comprehensive, so looking after all body parts and the mind, as well as longitudinal, so looking after someone over time. So not all people who are trained as family doctors are practicing in the sort of regular family practice. About 30% of family doctors in Canada are actually practicing in specialized areas like emergency medicine, sports medicine, sometimes hospitalist work, palliative care work, and some actually are working in walk-in clinics. So that's not practicing the longitudinal nature of family practice. So when we look across these countries, we see that, yes, part of the story is we need more doctors. And it seems that sometimes in Canada, what's happening is the family doctor workforce is being used in other parts of the system. But when we do a deeper dive, we see that more doctors alone likely won't solve the issue. And as Jasmine said, it's pretty complicated. And so this one slide has a lot in it, and you can certainly come back to it, but we're going to go into a deeper dive into each of these kind of pieces. So what we see here is that, funding is definitely one. So these are ways in which these other countries are kind of different from us. And in particular, I should say, our team looked at 4 of the countries in more depth: Finland, the UK, Netherlands, and Norway, and compared them to Canada. And so I would say all of the OECD countries we looked at, they all actually did have a higher proportion of total health spending that was public. And in general, these OECD countries, more of them, they spend more on primary care as a proportion of their total health budget. So there are some funding issues there. Then there's also just the way the systems are organized. So in many of these other countries, they actually require or they facilitate patients being connected to a family doctor or practice. And they're encouraging care close to home. Now, there's a lot more accountability for family doctors in some of these other countries, more accountability as to where you can work, what kind of work you can do. In some of these other countries, they have different kinds of insuring systems, and that allows them to. So, for example, in the Netherlands, they have 4 different insurers, and the insurer has some say then in whether you as a family doctor could set up shop and be paid by the insurer. There's different ways of organizing and paying doctors. So many of them have more capitation or salaried payments. All countries are kind of looking more towards healthcare, other healthcare professionals. We see in some of these other countries, they actually have far fewer walk-in clinics, and they have a much more organized after-hours care. And we'll go into that in a bit more detail. And then lastly, they have different information systems. So they have tools to help patients and providers communicate better with each other, and then they have better integration of the electronic records in primary care with other parts of the system. So this is just a slide that goes back to the funding, and we're going to go now into kind of looking deeper at each of these elements. And here, what you can see is the proportion of the total health budget that is spent on primary care. And again, you can see Canada circled in the red, and we see us far on the left because the proportion of the total health budget that we spend on primary care is about 5%. And the OECD average of all these other countries is about 8.1%. And you can see if we go across, there's actually countries who are spending far, far more on primary care than we are. Now, how does Nova Scotia compare to these other countries when it comes to kind of these other elements? So, we talked about the different ways in which people can be connected to family doctors. So in Finland, for example, people are actually automatically registered to a local clinic. And in Norway, they're automatically registered to a doctor. In the UK, local clinics, you're not automatically registered, but the local clinics actually have to accept you if you live in the area. There's kind of no choice that the clinic has to do so. And then in the Netherlands, there's choice of the local GPs. But if the GPs locally are full and they can't take you, the insurance provider really has to find someone to take you. So the accountability lies with the insurance provider, and there are 4 competing insurers who together cover all of the country. So contrast that with Nova Scotia and often the rest of Canada really too, where people are generally left to find their own family doctor. In Nova Scotia, there is a need a family practice kind of service, but the waits are really long, and it's not clear how effective that really is in matching people. In some provinces, you can actually search who's taking on new patients in the college website, but again, there's sometimes a very limited number who are. Interestingly, these countries do differ in whether they have a relationship with one family doctor. So it's not like everything is better in these countries. So in the Netherlands and Norway, they definitely have set things up so you do have an ongoing relation with the same family doctor or nurse practitioner. But in Finland and the UK, often your relationship is more with the clinic, and you may see different doctors at the clinic. And so there is actually a problem with lower continuity or relationship-based care. Contrast that to Canada, where we actually do have much more tradition of an ongoing relationship. However, at the same time, I'd say that with things getting bad, it seems that governments are investing more and more in walk-in clinic type of or episodic type of solutions that aren't actually providing that continuity to unattached patients. In these other countries, having care close to home is really important and actually encouraged. And in Canada, there's sort of no requirement. I think it's totally up to the patient where their family doctor is. Now, how about team-based care? So in Finland, interestingly, the nurses are the first point of contact, and they, in some other countries like the UK, nurses can independently provide some care, like while baby visits. There's increasingly in some of these other countries integration of other health professionals like physiotherapists and psychologists. Now in Nova Scotia, it seems like, it's a minority of practices that have other teams. So there are 96 collaborative family practice teams in Nova Scotia. Most, it seems, are family doctors, nurses, and Ps. When we look across the province, I think they only noted about 9 dietitians and 20 social workers. And so that's for everyone in the province. So you can see it's fairly limited. Contrast that to actually even Ontario, where I practice, and they're here about, it's not perfect, definitely lots that we need to improve, but maybe a quarter of people do have access to a team-based model where they do have nurses, nurse practitioners, social workers, pharmacists, etc. We can go further in trying to improve those teams, definitely in Ontario, in terms of having the other health professionals take on more of a role. One really interesting way in which these other countries are different is that they organize after-hours care differently. So in places like the Netherlands, for example, there's one number that you would call, or I should actually say Norway is the one I'm most familiar with. So there's not one number you can call, and that everybody, all patients, all members of the public know what this number is. So after hours, if there's an issue, you call this one number, you talk to a nurse who figures out, can you be seen the next day? Or do you need to be seen this evening? If so, she kind of figures out who could see you. Then you kind of meet the doctor at the clinic. And there's physicians who kind of rotate covering this clinic, and they serve probably like 100 to 200,000 people as a unit. And so you can imagine that, physicians, it's a large group of physicians who are rotating, being on call after hours. So it's actually not very burdensome to them compared to trying to be on call for their own practice. And it's really convenient for the public because it's very easy. You just one number to call. And interestingly, they have a lot more accountability for same or next day access. So there's few to no walk-in clinics in these countries. Contrast that with Nova Scotia, and actually, there's no contractual requirements for practices to provide after-hours care, but some practices definitely do that, but there's no requirement. And of course, in Nova Scotia and the rest of Canada, there are walk-in clinics, perhaps less so outside of the Halifax region in Nova Scotia. Interestingly, in Ontario, there is some accountability for practices providing after hours if you're part of both, 80% of practices are part of a group enrollment model, and there is some accountability in Ontario, but there is huge variability for how these are run. So how doctors are paid is different. Far more are paid by capitation, so that's patient payment per patient per year or by salary in these other countries. Compared to, in Nova Scotia, I think about 2/3 of family doctors are paid fee for service, and most of the remaining 1/3 are paid by about salary. So some salary, but not quite at the level where we see in these other high-performing countries. Interestingly, in Ontario, about 55% are paid fee for service, so a little fewer. So there's more capitation in Ontario than there would be in Nova Scotia. It looks like in Nova Scotia, there's some incentives to actually take on more complex patients and do chronic conditions, but not really incentives around quality of care as they are in Ontario and in many of these other countries. These countries differ, though, in the way that how the primary care clinic is governed. So physicians own and operate their own practices in places like the Netherlands and Norway, while in others they work in a health center, like in Finland often. In Nova Scotia, it seems like most primary care clinics are owned and run by doctors or by non-physician or corporate owners. And then there are, though, a few that are owned and operated by Nova Scotia Health. Similarly, in Ontario, most clinics are owned and run by family doctors, although team-based models in Ontario are nonprofit organizations. And so then lastly, accountability and governance. There's strong incentives for accountability for same-day access and quality of care in some of these other countries. more accountability for docs around where they can practice and the scope of practice, as I mentioned. So, in the Netherlands, it's not like you could just graduate as a family doctor and decide I want to only do sports medicine, and I'm going to just set up in this one, this specific part of town and only do sports medicine. Of course, in Nova Scotia and Ontario, you can do that as a family doctor. You can just decide where it is that you want to set up practice and what the scope of your practice is. And there's, in Nova Scotia, no real accountability for the quality of care or the roster size or timely access. And of course, we see, in Canada, about 30% of family doctors providing that specialized care. Interesting, in Ontario, there's a bit more accountability. So the team-based models in particular have to report on quality and other metrics, but there's very little accountability for the physicians, the physician parts of the practice and the physicians that are not in team-based practices. So just, one thing just to note is that, more and more we're seeing a shift to physicians working in groups. There's a minority of physicians that are working in solo practices across the country. Why is that important? Because we see that group practices in general are doing more of the things that we want family practices to do. More of them are able to offer after-hours appointments on the weekend, or work collaboratively with other health professionals, use electronic medical records in a smart way. So it seems like being in a group is advantageous. And we're seeing, more of our folks doing that. Although I will say, when we looked at the survey, it was interesting that many patients said that their doctors didn't have someone else who could cross cover for them if they were on vacation. So that's, although doctors are often working in groups, it's not clear that they're effective groups that can cover for each other. Interestingly, this is just some Commonwealth data looking at that after hours piece. So does a practice have an arrangement internally or with another practice where patients can be seen by a doctor or nurse when the practice is closed? And you can see the Commonwealth average is 75%. In Canada, it's 49% of practices saying they have other arrangements after hours. And in Nova Scotia, it's only 34%. So definitely an area where Nova Scotia and Canada are not doing as well as some of our comparator countries. The other area that really stands out in Canada is that, fewer people are able to get a same or next day appointment or after hours appointment in an easy way. Again, you can see same or next day appointment, 57% in the Commonwealth average in terms of people being able to say they can get a same or next day appointment when they were sick and needed care. It's only 41% in Canada, and in Nova Scotia, it was 23%. So we can see problems with timely access to care in Canada relative to others. So then the last major part in which we're comparing ourselves is with information technology. And so we can see in other countries, they often have better information systems that allow practices to communicate with patients using secure messaging, patients to be able to book using online booking, not having to call in to book an appointment as an example. They are a bit more sophisticated, I'd say, in using their electronic systems to be able to identify which patients need follow-up care. So that's practicing in a way that we say is like looking at your whole population, not waiting for someone to come in, but actually reaching out when you know something is overdue. So those countries are much better set up electronically to do that. And in some of these other countries, patients can actually access their whole health record online very easily, for example, in Finland. Contrast that with Nova Scotia or Canada, where few practices are using online booking or secure messaging. We have pretty siloed information systems, and our EMRs, our electronic medical records, unfortunately don't make population-based care or proactive care easy. And so this is just a snapshot just to say that actually most practices in Canada do have an electronic medical record. So that's not where we're falling through. Most of us as family doctors or primary care practices are using electronic records. It's more how are we using them, and are they able to actually help us in our practice in the way they should. And so what you can see here is this is a question from the Commonwealth survey, and it's a question to primary care doctors. So can you communicate, Can patients communicate with their practice via email or a secure website about a medical question or concern? And you can see, you know, in Sweden, 95% of people can do that. In Norway, it's 77%, but Canada's way down in the bottom, and only 23% of practices said that they have that kind of communication available for patients. The second one is about requesting appointments online. And again, we can see in the UK, like 91% of practices have an ability for patients to request things online. Contrast that with Canada being only, I think here it's 22%. Sorry for that formatting here. And so this is a very similar kind of snapshot where we're you know, Canada's underperforming relative to the Commonwealth, but you can actually see, you know, Nova Scotia is about at the Canadian average there. And then this is electronic communication between practices. So family doctors who report, can they electronically exchange the following with any doctors outside their practice? And the first one is patient clinical summaries. And you can see 63% in the Commonwealth Fund survey in other countries said that family doctors said they could. Only 25% in Canada, and in Nova Scotia was 31%. So still far below the Commonwealth average. And then this one is just about are other health professionals being used to care for folks with chronic disease. And again, you see Canada far below the rest of the Commonwealth countries, and Nova Scotia is sitting at about the Canadian average. Just before we end, I just wanted to say that one caveat is I've presented a lot of data from the Commonwealth survey, and the Commonwealth survey, for whatever reason, doesn't actually include a question related to relationship continuity. And that we know from lots of evidence that if you see the same clinician or family doctor over and over again over time, it actually means you have better health outcomes, you use less health services, there's lower cost to the system, you actually live longer. So lots of benefits. So really important. And Canada actually does quite well on that metric. So there isn't international data where I can show you how we do, but from the conversations I've had with others and the data I know in other countries, we are doing far better, we're doing very well, I should say, in this, because we often see the same family doctor or NP most of the time. We do have to, though, keep in mind that there's a growth of those walk-in clinics that's actually potentially threatening that. So in summary, we spend less on primary care than other countries. We have a similar number of family doctors, but fewer doctors total, and more of our doctors are doing specialized work or working in walk-in clinics. Other countries do organize care differently, often more geographically based, more physician accountability, more teams, more shared after hours, better use of information technology. And there can be some trade-offs, though, for patients. So some countries guarantee access to a primary care clinic, but then you might see different doctors within that clinic and not have that strong relationship. So there is some trade-off, but at the same time, then no one has going without a family doctor. All right, so I look forward to your questions and discussion.